Good morning, good afternoon, and good evening, everyone, and welcome to the fourth webinar in the Cardiovascular Connections 2022 series. Today's webinar is titled Moving for a Better Beat, How Exercise Benefits the Heart, featuring Dr. Louise Naylor, who's a professor in the School of Human Sciences at the University of Western Australia. Today, she will discuss the benefits of exercise to optimize and maintain the cardiovascular system. Before we get started, I'd just like to acknowledge our partners at the American Physiological Society and the European Council for Cardiovascular Research, and all of our series sponsors for helping to make this event possible. Okay, and without any further delay, I'm very pleased to welcome Dr. Louise Naylor to the floor. Louise, take it away whenever you're ready.
Thank you so much. And thank you to the American Physiology Society. It's a real pleasure to be here. So as you've heard, my name is Louise Naylor. I'm an academic and a researcher at the University of Western Australia. And for the past 20 years, I've also worked as an accredited exercise physiologist at Fiona Stanley Hospital in a cardiac rehabilitation program for the Advanced Heart and Cardiac Transplant Service. So the majority of my practitioner and research work is aimed at understanding how best to prescribe exercise for people at risk of or with established cardiovascular diseases. But before I start, in Australia, it is customary to begin with an acknowledgement of country. So this is the beautiful Perth on the western side of Australia, and it is situated on Noongar land. And I want to respectfully acknowledge the traditional custodians, the Whadjuk people, and their continued culture and the contributions that they make to the life of this city and region. So there are many claims. Companies, even celebrities, will try to sell you miracle cures, promising to help you live longer and be stronger or even more vibrant. But none are as potent or have the same amount of robust research evidence backing them as exercise. Exercise is the closest thing that we have to a magic bullet. Today, I'll start with a brief overview of the numerous benefits of exercise for cardiovascular health. And while it may seem simple on the surface, if we use this analogy of exercise as medicine and treat it like prescribing any pharmaceutical drug, we need to get the dose right. We also need to understand whether or not we need to titrate that dose, and also consider the frequency, and importantly, figure out which type is best for you. But when you hear the term exercise, everyone in this audience is probably thinking of something slightly different. Many of you may be thinking that I'm talking about jogging, like this guy here in the picture. I mean, he looks pretty happy jogging along listening to his music. But there are many different ways that we can exercise. And physiologically, this is important because the different types of exercise infer distinctly different stimuli for adaptations. So this is important to understand whether you are a researcher or you're listening to this out of self-interest, or whether you are a practitioner encouraging or even leading others in exercise. I will also then share with you some of the outcomes from our TWINS or STRUTH study that we have recently completed. So this study expands on the work related to different types of exercise, in which we combine a crossover trial design with our TWINS study. And this answers some fundamental questions about the individual responsiveness to exercise. And finally, I'll finish off by sharing with you some case studies to show the application and translation of this research. So this is nothing new. We've known it since the time of Hippocrates. Exercise is good for you. And the positive effects of exercise on heart health are abundantly clear. To show you just one of many examples, I've selected this data, which comes from Myers and colleagues. They looked at about 6,200 individuals and showed that exercise capacity is a better predictor of survival than any of the established cardiovascular risk factors. And we all know those. They are here across the bottom of this graph. So having high blood pressure, diabetes, smoking or being overweight, or having a bad lipid profile. So the graph that I'm about to show you looks at the relative risk of mortality, taking into account each of these established risk factors. And to guide you through these slides, I'm going to be using a traffic light system. So green indicates being fit. These are the people who you might think would be an elite level athlete, but actually it's just the general level of fitness of your average 60-year-old woman. So you'd be able to do most of the sports, go for a jog, maybe a little bit of a bike ride, or swim some laps. And this is the reference group. And then we have the group in yellow. So the group in yellow are those that are moderately fit, and the group in red are those that are unfit. Unfit, they're probably able to only do some light gardening or activities like golf before getting exhausted. The data is also presented in METs, so I want to take a moment to explain that for you, for those who are not exercise physiologists. So a MET is the metabolic equivalent. It is the amount of energy that you utilize when you are resting. And so if a activity has 8 METs, then that means that the energy that you're using to do that is about the equivalent of 8 times of your resting. So let's get back and look at this graph. So we have here the reference group of those fit individuals, and that gives them a relative risk of 1. What you'll notice is as I progress this and show you those who are moderately fit, there is an increased risk of death, regardless of which risk factor they have. And of course, those who are unfit have about a 2 or 2.5-fold increase of risk compared to those people who are fit. So we can take home from this that exercise is a better predictor of survival than any of the established cardiovascular disease risk factors. And the impact of exercise is independent of any changes in those risk factors. So here is another example to highlight this. Lee and colleagues collected physical fitness data and outcomes in thousands of people who had a repeat physical exam, and they were about 6 or so years apart between the visits. So the question that they were asking is, which is more impactful, a change in fitness or a change in fatness? So the participants were classified into whether they had reduced their BMI had remained stable, or they increased that BMI. And you can see that information here in the graph. Obviously, as you gain weight over the time period, you have a higher all-cause mortality. But look at this. This is where it starts to get interesting. Once you take into consideration whether their fitness also changed, we see that those who lost fitness, so these bars that are here on the left-hand side of the screen, have a much, much higher risk, almost 2-fold, regardless of what happened with their BMI during this time frame. And across the back row in the black, what you'll see there is even if you put a few pounds on, you're going to be much better off if you've also gained fitness during that same interval. So fitness is good, and hopefully I have convinced you of that. Okay, so if we think of exercise as medicine, how do we know what the correct dose is? The recommendations that have made it into all of the guidelines around the world is that we should be doing 7.5 MET hours per week of moderate or vigorous physical activity. To put that into context, we're looking at about 30 minutes of moderate exercise, like going for a brisk walk, on 5 or more days a week, which equates to roughly about 150 minutes of accumulated exercise across that week. So this graph here, we're again looking at mortality risk. The area that's shaded in red here are what happens to that risk if you take people from being inactive, doing no activity, to meeting those guidelines. And you can see that there is a significant 20% reduction in their mortality rate. And doing a little bit better, so the next group, these are those who are meeting the guidelines and maybe doing twice the recommended amount, have a slightly more benefit. And that trend continues as we go across. But the burning question for many of you may just be, what's the bare minimum that you can get away with and still have health benefits? And I know a lot of my patients ask me this. So this publication from The Lancet set out to answer exactly that question. And what is the answer? Well, as little as 15 minutes of physical activity each day is associated with a massive 14% reduction in all-cause mortality. So this is consistent whether you're male or female and across all age groups. So it seems that the biggest bang for our buck is moving the population from being inactive to meeting those guidelines. This paper also reported that if an inactive individual engaged in low volume exercise every day, we could postpone 1 in 6 premature deaths. This is a similar magnitude of success as tobacco campaigns. But seeing the relationship between physical activity levels and heart health some are tempted to think, well, if exercise is good, maybe more would be better. But here there seems to be that there is a slight reduction in the additional benefit that you're getting. And this starts to plateau once you're at around 3 to 5 times the recommended minimum. And then there is this controversial uptick that I've circled for you here. Those who do excessive amounts of exercise might have an increase in mortality risk to those who are performing the recommended amount and slightly more. And yes, before you think, well, who cares? This is relevant. In Australia, more than 30% of the adult population exercise in excess of this upper range that's been studied in the literature. And also in America, the number of individuals participating in marathons has increased by more than 25-fold over the past 40 years. So maybe even some people in this audience, there are quite a few people that are doing excessive amounts of exercise. And of course, there are those not so uncommon cases. They're high-profile athletes that during an event on the field have a cardiovascular event, and it's viewed by millions. These are more likely to make the media, and we've all probably heard of some anecdote, someone's friend or your relative who was super fit and they suddenly collapsed and died from a heart event. And these stories, they stick with us. This has been termed the too much exercise hypothesis, which suggests that large volumes or intensities of exercise may have a detrimental effect on the heart. But we need to understand those risks so we can mitigate them. And of course, there are lots of epidemiological studies which indicate that there is no evidence of harm even if you are doing 10 times or more the recommended minimum level of physical activity. But let's have a little look at what could potentially happen to put the heart in danger if we do excessive or extreme volumes or intensities of exercise. So there are many studies out there which have shown that there are temporary cardiac dysfunction following extreme acute bouts of exercise, such as increase in blood markers, such as cardiac troponins, BNP, and these are specific for cardiomyocyte injury. There are also studies showing that there is a reduction in cardiac function, which also can be referred to as cardiac fatigue, with one study reporting that about 75% of athletes showed some new wall motion abnormality following their race. And then there's some data to indicate that repeated bouts of cardiac fatigue may predispose the myocardium to fibrosis or scar formation, especially in the setting of inadequate recovery. And myocardial tissue may potentially act as an arrhythmogenic substrate, leading to arrhythmias such as AF. And there are, of course, some studies that are reporting athletes have an increased level of atherosclerosis or coronary artery disease, despite the fact that they have a better overall cardiovascular risk profile. While there is still much to understand in this topic, I currently favour the theory that these may be a protective adaptation in most cases. So, for example, the release of those blood markers with exercise may be a protective process or a precursor to adaptation, similar to what we observe in the skeletal muscle, where muscle damage occurs with excessive exercise, but this allows us to grow with our muscles and get stronger. Same for cardiac fatigue. Again, perhaps similar to the skeletal muscle. We've probably all experienced DOMS or delayed onset muscle soreness after a heavy session. That muscle pain, similarly, in the heart may follow an extreme exercise bout and help with the remodeling of the heart. And just a quick note on the myocardial fibrosis and coronary calcium scores that have been noted in studies in athletes. These are atypical, and usually with closer inspection, we find that they have had prior history or extensive coronary artery disease risk factors. Unfortunately, I don't have time to go into this in detail, and it's really not the purpose of my session here today. But if you are interested, I highly recommend you look at this review for further details. Again, to reiterate, the benefits of exercise generally outweigh the risk, and there are distinct mechanistic pathways that differ between pathological and physiological beneficial changes to the left ventricle. So in summary, there is some pretty compelling evidence that going from sedentary to doing just something reduces your mortality risk by an amazing amount, about 20%. Even as little as 15 minutes of exercise each day reduces your risk of death. And if you want more convincing data, we can look at the study looking at the former Tour de France cyclists. These are athletes who train and compete in one of the most grueling, extreme endurance events. It really pushes the limits of the human body. But in this cohort, there is a massive 41% reduction in mortality of the cyclists compared with the general French male population. So for me, the jury is out. Exercise wins. And it's made it to the cover of the Times magazines, and I will read from this article. As time goes on, paper after paper after paper shows that the most effective, potent way that we can improve quality of life and duration of life is exercise. But not all exercise is equal. The heart is essentially a muscle, and like any muscle, it adapts to exercise. The increased size of the heart is one of the key adaptations that allows an athlete to generate a high cardiac output essential to support the extremely high demands of oxygen uptake of the muscles required for elite performance. So in the mid-1970s, with the introduction of echocardiography, which is ultrasound imaging of the heart, Morgenroth recruited a mixed bag of athletes. There were some swimmers, some runners, and some wrestlers. And he showed that compared to the untrained individuals, all of the athletes had this classic athlete's heart of an increased left ventricular mass. But when he divided those athletes into their sports and looked at the pattern of increased left ventricular mass, he made some very interesting observations. What Morgenroth noticed was the patterns of left ventricular hypertrophy are different and appear to depend upon the nature of the exercise conditioning characteristic of each sport. In other words, athletes like the wrestlers or lifters who competed in resistance events showed a pattern of hypertrophy commensurate with a concentric hypertrophy, whereby the walls are thicker and the internal cavity of the left ventricle size remained the same. And in contrast, athletes who competed in endurance-based events had an eccentric or an outward remodeling, where the increased left ventricular mass was predominantly through an increase in the left ventricular cavity size, while the wall thickness remained within normal parameters. And this hypothesis of Morgenroth made sense conceptually, because it's based on the law of Laplace, which states that the wall stress is directly proportional to the left ventricular pressure and radius. So in other words, if you put increased stress on the heart, then to normalize that stress, the cardiac muscle will grow to match the workload imposed on it so that it can maintain a constant relationship between the chamber pressure and the ratio of wall thickness to the ventricular radius. So as a consequence of the pressure overload, so think about an increase in systolic blood pressure, which is produced during strenuous resistance exercise, we would see a concentric form of hypertrophy. And in contrast, the increased left ventricular mass induced by endurance training, where there is a prolonged repetitive volume overload on the heart through the large venous return filling the heart, creates an eccentric form of cardiac hypertrophy. But this may have been too really simplistic. And so as I started looking at it, there was just a few things that didn't make sense. And I remember taking this to Danny Green, who you can see here, who was my PhD supervisor at the time. And I had a few concerns. So first of all, this concept of concentric hypertrophy just didn't make sense to me. It doesn't increase cardiac output, and by increasing the wall thickness, then you would need to increase also the myocardial oxygen demand, which would not be conducive to high levels of athletic performance because it could lead to that mismatch of oxygen supply and demand. So Danny and I published this appraisal of the Morgenroth hypothesis, and we highlighted a few key considerations. So namely, there didn't seem to be any clear evidence that there was an intense increase in pressure overload with resistance training. This work by Hakowski shows the left ventricular end systolic wall stress graph during heavy bouts of leg press exercise. So you can see here in the yellow, you've got 80%, 95% in the black, and in the silver, 100% of their maximum capacity. Not only was there not an increase in stress on the left ventricle, it was actually decreased. And the uncertainty about the exact nature of the changes of the left ventricle in following repeated resistance exercise came from a small number of studies, and they all had a low number of athletes. And of course, there was this issue of prevalent use of anabolic steroids in this group, which have a profound impact on the heart. So another challenge with interpreting the literature backing the Morgenroth hypothesis was that most of the studies have used older and less sensitive imaging modalities. You can see the clear difference in the resolution between an MRI image on the left-hand side of this panel versus the echocardiogram, which is on the right side. And I've included this information here from Bellinger just to highlight the difference in the ability for MRI versus echo to detect small changes in the left ventricular mass. And of course, remember that the initial studies were conducted using one-dimensional or M-mode imaging, and the resolution was much poorer than what you're looking at here. So often, the reported differences in left ventricular mass and dimensions that were reported were well within the error of measurement of the technique. And lastly, the large majority of studies were cross-sectional in nature, and they often overlook scaling. And this is significant in athletes because athletes come in all different shapes and sizes. These are all Olympians. They are elite level athletes that are at the top of their sport, but clearly they come in all variety. So we can't just compare one with the other. We need to scale them to account for these large differences. So taking all of these concerns on board, we designed what we thought was the optimal study, and we recruited my first PhD student, Angela Spence. For this study, we recruited previously sedentary males to see whether or not we could induce changes to their left ventricular mass. And to overcome the limitations of cross-sectional studies, we used a prospective longitudinal exercise training study, and we also used cardiac MRI to make sure that we were getting the most accurate images that we could. So the males were randomized into either a resistance or endurance training group, and the program lasted for 6 months. All exercise sessions were center-based and fully supervised. Cardiac MRI was performed at baseline and following 6 months of training, and although I'm not going to be speaking about it, we also looked at detraining data. It was long, labor-intensive, and expensive. But our results showed that following endurance exercise training, the left ventricular mass increased in correspondence with an increase in left ventricular cavity size, indicating an eccentric form of left ventricular hypertrophy with endurance training. And here in the light blue, you can see that we didn't observe any significant adaptations to the left ventricular mass following resistance training. So many years after raising the concerns about the validity of the Morgenroth hypothesis, we produced evidence to support that endurance exercise training does in fact lead to that eccentric form of hypertrophy. But we are yet to be able to support the hypothesis that resistance training leads to concentric hypertrophy. But for anyone who's working with athletes or even clinical patients, research is sometimes hard to translate because we don't train groups. We train individuals, and not everyone responds identically. So when we re-looked at the data by Ange Spence more closely, and we looked past the group averages, we realized a few things. While the group averages are telling, sometimes they can mask what is happening to each individual. So we realized that the participants who engaged in the endurance exercise training were more likely to have an increase in their left ventricular mass, with only 20% not responding. But surprisingly, half of the individuals who did the resistance training had a reduction or the opposite effect of what we would expect with their left ventricular mass following resistance training. So this intriguing finding raised a lot of questions for us. And we also appreciated the limitation of that study, which was that the participants only performed one mode of training. So there was a possibility of some selection bias being shown. The questions we wanted to understand was, do individuals respond to different types of exercise? Things like, are certain individuals naturally better at one form of training than another? Or if you're good at one type of exercise training, does that mean that you respond well to all forms of training? Or is it mode specific? And it turns out that these questions were very relevant, questions that the general population wanted to know the answer to. So this program of research quickly was picked up by the international news. But before I show you the study or the results, I have to thank and acknowledge the hard work of Channa Marsh and Hannah Thomas, our two PhD students who worked on this massive study. So in the STRUTH, or Studies of Twin Responses to Understanding Exercise as a Therapy study, we employed a crossover design, meaning that each participant completed both types of exercise training. So essentially we compare their response to resistance exercise training with their own response to endurance training. But we were also wondering whether the left ventricular response to exercise was genetic. So we came up with combining this with a twin study design. So we recruited twins as a twin pair and randomized them to either the resistance or endurance exercise program. Then we gave them a washout period and made sure that they returned to their baseline values and crossed them over. So as a twin pair again, they did the alternate form of training. And you can see in these pictures here, the twins actually trained side by side, where one was spotting and the other was doing the lift, or they were next to each other on the bike for every single session so that we knew that they were doing identical exercise. So the theory behind a twin study design is this. Monozygotic or identical twins share 100% of their DNA, while the dizygotic or fraternal non-identical twins share about 50%, like any siblings. But if you look at the way in which the identical twin pairs react, it can tell us whether that trait is genetic or not. So if monozygotic twin responses are almost identical, but the dizygotic twins are not, we can surmise that the intervention has a strong genetic component. On the other hand, if everyone's responses are mixed, with some twins, both identical or not, responding more or less than others, then genetics is less significant. And we point to lifestyle or environmental factors such as their diet, education, weight, and so on. And here are our results. Fitting with the previous work from our lab, we saw that there was an increase in left ventricular mass in gold, and this is the endurance group. And yes, there was an eccentric pattern of hypertrophy with an increase in left ventricular internal diameter. However, in blue, what you're seeing again is a slight decrease in left ventricular mass with resistance training. But plotting the individual data shows that participants were more likely, or 72% of them in fact, to respond to endurance exercise training by increasing their left ventricular mass, whereas a much smaller percentage of participants, and remember, these are the same participants who did both types of training, had an increase in left ventricular mass following the same duration of resistance exercise. And these are concordance plots of the response of the left ventricle to exercise. The response to resistance exercise training is on the x-axis, and it is plotted against the same individual's response to resistance exercise on the y-axis. So those here in this green quadrant responded to both types of exercise. The individual dots that are in the yellow segments means that they responded by having an increase in left ventricular mass to one mode, but not the other one. And you can see a few people in the red quadrant on the bottom left, and they were the ones who did not respond to exercise by increasing their left ventricular mass to either form of training. But there were very few people who saw no response to the left ventricle following 3 months of endurance or resistance exercise training. So to interpret this for you, this data shows that if you start exercising and you do not seem to be getting the benefits that you had hoped for, you might be able to switch up your routine to get those benefits, because one or the other type of exercise will give you that adaptation for the vast majority of people. And the final question that we addressed was whether or not the left ventricular response to exercise was genetically determined. Are you born to be a good athlete? So at entry, the left ventricular mass was determined to be a combination of both genetic and shared environmental factors. So yes, slightly determined by your genes. But in response to exercise training, it was a mixed bag. So remember, this suggests there was a limited genetic contribution, and further analysis helped us to reveal the greatest contribution to the magnitude of response of the left ventricle to exercise training was an unshared environmental condition. So good news is that there is no evidence to suggest that your responsiveness to exercise training is modified by your genes. And quickly, just to touch on gender, these changes to the left ventricle were dominated by adaptations to the males that you can see in the blue bars. And again, an increase with endurance training on the right-hand side and a decrease with resistance training. And you can see that the magnitude of change was much smaller in the females, and we weren't able to show the eccentric remodeling occurring in the females. But that's an area that we need to look at in more detail. It has been looked at by Howden as well, and this is a 1-year exercise training study looking at the difference of males in the black bars and females in the grey bars. And what you will notice is that the females had a much quicker response that plateaued. So their VO2 in panel A and their left ventricular mass in panel B started to plateau after about 3 months of exercise training, whereas those males could continue to get an increase, and it wasn't until about 9 or 12 months of exercise training that they were plateauing. But remember, I also hopefully convinced you that exercise is also good, not just for healthy people to remain healthy, but exercise is a great medicine for patients. So I was interested in whether or not the structural changes that we've already highlighted in this presentation so far could improve the function of the heart. So this data here comes from elite level athletes. We studied their hearts as they resumed training after a break following the Olympic Games. So even the fittest of the fit, and many of the participants in this study got a medal within the Olympics, and we saw that their hearts were still malleable to change. So as they came back at baseline, their hearts were much larger than the white control participants, but as they continued to exercise, their heart muscle continued to grow. But the question still was, well, what about the function? Could we also change the function? But before we get to that question, I'm going to have a little segue, so remember that. Perhaps first we need to talk a little bit about what cardiac function is and why it matters. So we know that there is a relationship between the function of the heart and exercise capacity. And this has been shown on the left here using the older transmitral markers of diastolic function, and more recently the data on the right using global longitudinal strain, which is a sensitive indicator of left ventricular function. And this is because exercise places a significant demand on the cardiovascular system. We need to increase that blood flow to deliver more oxygen and nutrients so that we can continue exercising. And this occurs predominantly via enhancing the left ventricular diastolic filling. Otherwise, there would be an increase in pressure within the left atria, which would impair the pulmonary function. So early measures of diastolic function, like transmitral E and A velocities that we saw in the previous graph, are measured relative to the direction of the ultrasound beam, and therefore they yield only one longitudinal component of left ventricular mechanics. But the diastology of the heart is a lot more complicated. As the heart not only contracts and relaxes, but it also thickens and contracts and twists. There are helical-oriented myofibers, which move right or left-handed pathway, and therefore the contraction also induces a shear strain within the myocardium. So towards the end of systole, the stored pressure is released and the left ventricle starts to untwist in a clockwise direction at the base and counterclockwise at the apex. And approximately half of this untwisting occurs prior to the mitral valve opening. Untwisting supports a rapid reduction in left ventricular pressure, which allows the left ventricle to fill and keeping the left atrial pressures low, and it almost creates a suction, allowing that blood to go into the left ventricle. Okay, so let's get back to our story. What about cardiac function? Can we improve function with exercise training? And this is important because what we noticed when looking at a group of obese individuals was that there was a reduction in their diastolic function, which occurred independent or prior to any changes that we were able to observe in their left ventricular morphology. So these obese individuals, you can see that their left ventricular mass, especially when we take into consideration the scaling for body weight, was on par, if not slightly smaller than their lean counterparts. So getting back to the rowers, we also looked at the function of their hearts. Remember, they also have large hearts, which almost are the same size as these pathological conditions like obesity. When they were not training, so when they returned from their rest period, there was a reduction, significant reduction in their diastolic function compared to the white, which you'll remember are the controls. But as they started to resume their exercise training, within 6 months of training, that diastolic function was normalized. So based on this data from our rowers, we were wondering whether exercise could then possibly be a nice way to improve diastolic function of the hearts of these obese children and adolescents. And we chose obese children and adolescents because their hearts are large. They also have some diastolic impairment, but they are young and they are free from other established cardiovascular disease risk factors. So if there was going to be a change, it's most likely to be seen in this group. So again, we recruited another group of obese adolescents and randomized them to exercise, and it was a resistance training protocol, or to be in the control group. And we saw that resistance training improved their diastolic function, independent again of any changes in morphology of the left ventricle. So encouraged by this, we turned our attention to the most sick of the sick, and these are patients with advanced stage heart failure with a reduction in ejection fraction. And we did a similar thing. This time there was 3 groups: a control group with no exercise, a group that did endurance exercise training in the blue column at the bottom, and in the gold are those that did resistance exercise training. And while we saw no significant changes in the dimensions or the volumes of the left or right ventricles, we did observe that there was a differential effect of endurance training as opposed to resistance training in this cohort of patients. We can only speculate why this might be. So we saw that aerobic endurance training in the blue was actually showing us evidence of worse diastolic function, which was not apparent with resistance training. And we think this might be because of that chronic exposure or the volume overload, which is associated with endurance training. So there is an increased venous return, and this may, in a failing heart, which already has got diastolic impairment and isn't contracting well, overload the ventricle and displace it along that Frank-Starling curve. So the resultant following contraction would be impaired. But then zooming out and remembering that the cardiovascular system is actually the cardiac and the vascular structure, we thought that maybe another explanation could be that during resistance training in these patients with reduced heart function, it had something to do with the blood vessels. So we'd previously shown that exercise, and particularly resistance training, leads to a superior peripheral vascular remodeling. So in the context of those heart failure patients, this may result in greater compliance of the peripheral vasculature, which can then accommodate the higher volume load associated with exercise training, a potentially lower afterload and preload after resistance training due to that increased vascular compliance. But now we'd like to apply this information. Is it real? Can we apply it to individuals? So to do that, I would like to introduce you to Christian. This is Christian. He is a 22-year-old male. And his medical history is complicated. This is Christian just after having a heart transplant. So he came, there was some complications with that and leading up to the heart transplant. So he had a prolonged period of bed rest, cachexia and severe deconditioning. At the same time, he also had Marfan syndrome and a Bentel's procedure. So we weren't able to increase, or we had to be very careful to reduce the increase in systolic blood pressure, but to be able to recondition him. He came in and he was 50 kilograms and he's about 6'3". So we had done some work previously on eccentric exercise. So an eccentric contraction is a contraction where the muscle is lengthening. In the usual contraction, the muscle shortens, you'll remember. So this contraction targets the skeletal muscle, which means it can produce about 4 to 5 times greater increases in power output. And chronically, this leads to a much larger gain in skeletal muscle mass and strength. We've also been able to show that it has a lower cardiorespiratory demand and that your heart rate, blood pressure, and VO2 are much lower when compared to the typical concentric exercise. So this is a more for less approach where you can build your more muscle without taxing your heart and lungs, which seems designed for heart failure cohorts. And I just want to go back and say thank you to Lauren and Lucy, who have done a majority of this work. And so here we go back to Christian, and we thought perhaps the solution for him was that eccentric cycling. So here he is performing his eccentric cycling, and I can proudly say that within a matter of weeks, we were able to build up his strength and condition enough that he could go back and take part of life, go back to his regular gym. He gained 8 kilos within a month of muscle, and he's now back to studying and back to doing all the things that he wants. So eccentric training really helped us to rehabilitate this guy. Our next story is that of Sophie. So Sophie came to us as a 9-year-old and she had a sarcoma in her leg. That required aggressive therapy, and she was able to beat her cancer. But the very therapy that saved her life affected her heart, and she developed heart failure and needed an emergency implant of a mechanical assist device. So an LVAD, which is a pump that helps the function of her heart, was implanted. And as you can see, her exercise, she was very frail and her exercise capacity was almost nothing. So the first time that she came in to see us, she did 6 minutes in total on the treadmill, but required frequent rests and kept saying that she was tired. But looking at her function, I thought she had a lot more that she could give us. And we had done some previous work looking at the cardiac structure and function of the heart following chemotherapy, and knew that she would be able to tolerate more. We had also done some work looking at how to make exercise fun for children. So this is the work of Howard and Andrew Mills, and I'd like to acknowledge them for this work, where we saw that exercise using the exergaming, which is an active form of interacting with your Xbox and playing physical activity, actually could infer significant improvements in vascular health. So we thought, well, maybe this can give improvements in overall health. And we also knew that one of the main aims of exercise rehabilitation is to build those lifelong engagements of physical activity. So we thought we'd combine this for Sophie. And here she is at her 4th session. So remember, just 1 week after being able to do 6 minutes with frequent rests, by mixing it up and giving her a little bit of fun, we introduced the Xbox Just Dance. Here she is. And so you can see how by introducing something fun, dancing is what she wanted to do, in a controlled manner by having technology help us with that, we could promote her adherence, but also get her to do a lot more work. So what you're seeing here is that she was able to exercise for 45 minutes without needing a break, and her heart rate got up to 145. And all throughout that, all she complained of was being a little bit puffy, but generally well. And she also set a new record on the treadmill. She took a minute off the time that she needed for the distance. But as her confidence and endurance began to improve, we introduced other activities like boxing to focus on her strength. And very proudly, I can share the results of this. So this is Sophie's 6-minute walk test results. So that's the distance that she can cover in 6 minutes. What you're seeing is, as she first came in to see us, it was severely decreased. It was well below the 10th percentile for her age and gender. But when she came back from her VAD being put in, and we started engaging with her more and being able to make her therapy more fun, we had dramatic improvements. And very quickly she got to the 25th percentile, the 50th percentile. And before she was eligible and went to have her heart transplant, she was above the 90th percentile of people for her age and gender. And here she is, just 8 days after having had her heart transplant, healthy, well, and now she's actively dancing 6 times a week and back at school and able to engage in everything that she would like to do. So this is another example of how our research has been able to really aid people to get back the quality of their life, and to mix up what we're doing to really think about how we can apply all of our knowledge to the individual person. And so I started off by acknowledging the country, and I would like to finish off by acknowledging the people. These are the amazing people that I've had the pleasure of working with, PhD students, master's students. I cannot thank you enough. And a special thank you to Danny Green, who's been there right from the very first day of my honours all the way through. It's been an absolute pleasure to work with all of you, and thank you.
Fantastic. Thank you so much for that, Louise. Okay, so this person has asked, does the magnitude of the response to exercise differ with ethnicity?
Good question. So there was recently a paper, and I've referenced it, the Lancet paper in the initial part of my presentation today, which actually goes into the different responses. And they looked at a large number of people from all different types of countries. There were 70 countries that were involved in this. And what they were able to show was that the benefits of exercise were there regardless of the socioeconomic status and regardless of which country you're in. So we don't know if we can answer yet whether the magnitude changes, but we definitely know the benefit is the same, and that it is still significant. Yeah. So I'll refer you back to that, and I'm pretty sure it was published in the Lancet just this year.
Great. Okay. Next question here. First, a compliment, brilliant work, and thank you. And the question is, can you comment on what causes the increase in the LV wall? Is it more blood? Is it more tissue? Is it a combination of both?
We're actually seeing that there's a growth in the myocardial tissue. So there is a growth there, which is caused by the increased load that comes so that it can accommodate holding more blood. There were some studies done by Ben Levine and his group, particularly in Dallas in America, where they were looking at whether you change the volume and whether that is what is affecting it or not. So you can change the preload, and the way that they did that was by infusing saline. And so that is part of what we are seeing, but obviously with time, that ventricle is going to get larger, and that is not just that you're stretching it further, but you're also then accommodating by building more tissue. We also know, well, theoretically, that if you do more resistance training, then there's going to be more increase in the cardiomyocytes, which is going to be the left ventricular mass there that is being induced by an increase in the wall thickness and cardiac muscle rather than volume overload. I hope that answers your question.
I think it does. Fantastic. Okay, next question here. This is a long one, so I'll read it. In relation to the excessive exercise that you mentioned early in the talk, given that these studies typically do not differentiate between the manner in which the dose of exercise is made up, could the issue be that many of those training at high doses are not distributing intensity appropriately? So, for example, they're training too hard for too long or too hard for not long enough.
Lovely. Thank you, John, for that question. Yes, it is something. And in the exercise physiology literature, we talk about polarized training. So polarized training is the concept where you don't do all of your training flat out. And in fact, what we've seen from a lot of elite athletes around the world is when you look at their training consumption, it's made up of basically 80% or 75 to 80% of low intensity exercise. And there's only the last 20 or 25%, which is made up from that high intensity. Whereas a lot of people, when you're starting off, you want to do as much as possible. And so there is probably something to do with not getting enough of recovery. And I mentioned, especially with the fibrosis and the scarring of the ventricles, we're seeing that with individuals where there is a excessive and continuous too much, too high volume, too high intensity without enough recovery in it as well. So while it's not all of us and not the people who are under a good program, particularly those people that are seeing a little bit more of the events, like those stories that we hear about where someone has an event during a marathon or a fun run or something like that, that is more likely to occur in people who haven't trained as much. So that does indicate to us that maybe if we aren't balancing our intensity and our volume, then that puts us at a higher risk. So I feel that polarized training might actually be the way to go, and that we should be listening to our bodies and giving it a bit of a rest and not always be pushing to our maximum to try to get maximal benefits.
Mm-hmm. Great. Awesome insights there. Okay, next question here. Has there been any evidence of isometric exercise impacting cardiac structure / function?
Good question. A little bit. It's hard to distinguish and differentiate because the acute changes is something that we're just starting to look at. So we've recruited a group of PhD students at the moment where we'll be looking at what actually happens during or immediately after an acute exercise bout. When you're looking at an elite athlete that has had a lifelong history of exercise training, we can't really differentiate whether that training is isometric or isotonic or what the majority of it is. So we don't yet, as far as I know, have the answer to this, but we'll be looking more and more at it. So over the next couple of years, hopefully, we'll be able to answer that question about your isometrics.
Amazing, and a great avenue for future research there. And I think just looking at the time, I'm going to make this our last question. So, would results in left ventricular hypertrophy be similar between high intensity interval training and steady state endurance training?
Yep. I knew that question would come. High intensity interval training seems to be everywhere. Everyone's interested in it. There is probably some evidence to show Erin Howden and her work really looking around high intensity exercise training and what happens there. And because there will be larger changes in the preload or the afterload, depending on which type of training that you're doing, but this was endurance, I think, so more preload. Potentially, we're seeing some signals that there might be slightly larger or different changes there. But again, how do we distinguish what it is acutely that's causing that adaptation when you're repetitively having stimuli again and again over a period of sustained 3 months or more that you need to have adaptations? So, yeah, thank you for that question as well.
Awesome. Okay, well, I just want to thank you again so much for your time and your insights, especially during the Q&A. It really was a pleasure to have you here with us, and I hope that you had fun.
Thank you very much for having me, and good morning from Perth. See you all. Have a lovely day.
All right. And I also want to thank our audience for joining us live. We really do these events for you guys, so thank you for being here. In closing, we hope that you enjoyed this Inside Scientific webinar produced in partnership with the American Physiological Society and the European Council for Cardiovascular Research, and we look forward to having you with us again for the rest of the series.